Okay, so we are going to discuss chapter 8, hemostasis. And there are a couple of students who are going to miss it. So for them, I am going to record this chapter here so they can use it to, to catch up. So in our operating room situation, as you know, you already have understood so far that maintaining hemostasis is one of the major challenge in our operating room, because when surgeon makes incision, from that point on, the tissue starts to bleed. For skin and epidermis area, dermis area, subcuticular tissue, the layers of the skin to the targeted organ, when you are going step by step, your surgeon is incising through it, he has to maintain hemostasis as he proceeds through the through these layers. So our goal, let's make it a presentation mode. Got it, presentation mode. Our goal is to provide assistantship, provide the instruments, the items that is required in order to surgeon to, in order for the surgeon to maintain hemostasis. So starting from the top, when we are right underneath the skin, when those fine bleeders starts to activate and bleed, and they go through this process, natural hemostasis process. So we have to learn what is this natural hemostasis process, so we can understand the mechanism behind natural hemostasis, and we can then help the natural hemostasis to enhance and control bleeding so that the blood loss is minimized. So here you can see vessels. When there is a trauma to this vessel, injury to this vessel wall, it starts to form a plug, which is clot. Basically, the common term for that is clotting. Now, what happens is vessels, nerve endings signals the blood to bring in a component called platelet. Platelet from all around the area will come to this targeted area where there is a little cut. And the platelet will also stimulate other components to come and sit there to form a platelet plug. Those components are commonly known as fibrin or fibrinogen. So together with the fibrinogen or fibrin and the platelet, the clot formation takes place. And that fills in the gap where there is a little injury that seals the gap, the cut area, that seals that area and controls the bleeding. This is natural process, and it works when we have a tiny bleeder. So vasoconstriction is the first response. The area where there is a cut, that area constricts, the blood vessel constricts. Second is platelet and fibrinogen comes to that area and plugs that area, starts to form a plug. And third is when the plug is actually formed, agglutation by the agglutation, the clot formation, then we have a seal in place and the blood vessels is not hemorrhaging anymore. That's the normal hemostasis. Now, we have few terms that we need to learn. Number one is anticoagulant. This is opposite of coagulation. We learned the coagulation, that is the natural process of blood vessels to seal the bleeder. But anticoagulation is when substance can be given to the patient to prevent forming this clot. This is where we're seeing here clot formations, blood vessels, and for some disease condition form clot automatically without any bleeding, without any hemorrhage. These components in the blood vessels, platelets, are somehow triggered to form clot when that clot is not required. And for that clot formation problem, what happened is blood vessels cannot transmit blood through it because the vessels gets constricted. These clot is sitting there and blocking the blood vessels to flow the blood. And that is when we need to give, surgeon needs to provide a anticoagulant, a substance that will break down these clots. Anticoagulants is basically a clot breaker. Next, we have coagulants. Coagulants, on the other hand, is required when the patient's own clot formation process is damaged. Patient when have diabetes, for example, other blood-related disease, they have the system is damaged. They got their system which do not allow clot formation, which is supposed to do when there is a bleeding. So these patients, when they have a cut in their vessel, they cannot form clot and seal that blood vessels, and they just bleed and continues to bleed. Like when the patients are taking aspirin for pain, those people who are taking daily aspirin for pain, they have a tendency to bleed and they cannot form clot. For them, there is a substance available called coagulant. This substance promote and it'll speed up the process of blood clot formation, and in terms this will help hemostasis process. So coagulant and anticoagulant, two of them that we see, they are working in two opposite directions. Now, hemostatic agents. When we have bleeding during the surgery, for example, here, a thoracic cavity is exposed with a retractor, and we can see the underneath the organ, which is encapsulated with fat and connective tissue, and it's bleeding slowly, but continuously it is bleeding. And this type of bleeding can be stopped by using hemostatic agent. Hemostatic agent is an external agent that is available from the pharmacy in a many different shape and in many different consistency. Some of them are liquid, some of them are powder, so you can have many different, some of them are just like a little sponge. Here we are seeing use of powder type of hemostatics. That hemostatics, the powder form, has been sprinkled all around it, and that is going to stop the bleeding process here. So hemostatic is the agent that you use during your operating room procedure. During any surgery, you will have some form of hemostatic agent. This is one of the form, we call it Avitin powder. You will go to, you'll get that name later, so you don't have to write it down right now. So now just know hemostatic is a substance that helps to stop the bleeding. It helps to form the clot and reduce the bleeding. Next, we have a natural element in the blood, which is called platelets or thrombocytes. These platelets, they are tiny particle. They run in the blood vessels. Every patient has platelets, and these platelets form the clotting. As you have seen, this platelet comes to the area of bleeding where there is a cut. That is the area platelets are, they come and they plug that gap, seal that bleeder by generating clot formation. So platelet is a substance that is required for natural clot formation. So during the surgery, surgeon checks the platelet number of a patient. They like to run a blood test right before the surgery and during the pre-op also, and check if the patient has enough platelet to have this type of platelet clotting formation. We call it platelet aggregation. It's a clumping action of the platelet, goes through a complex mechanism. We're not going to go through that physiology. You have already learned that physiology in the previous chapter during your anatomy and physiology lesson. So platelet comes here with that aggregation method, it seals the gap. And blood clot is formed. Blood clot is also called thrombus. So platelet is required for this type of aggregation. And if the patient don't have enough platelet, then they cannot form blood clotting using natural process. And these people, they tend to bleed a lot during the surgery. Now, if they have too much of a platelet, then there is a problem also. Then what happens is they have a tendency to form clot like this here. This is the blood vessels, and there is clot formation here. And this is not induced by any bleeding, any cut in the vessel. This is just having too many platelets. This person, this patient, spontaneously form clot. And this type of clot, when it is formed, we call it thrombus. It is stationary in one place of this blood vessels, and that needs to be broken down. So thrombolytics, thrombo means this clot, and lytics, something that breaks it down. So thrombolytics component, substance, we can pass it through a catheter, and we can break this clot. So the blood vessels can open up, and it will flow blood to the targeted structure or targeted organ as before. So when people have stroke right here, in this person got a stroke here, you can see dark clot here, they can have catheter, and catheter other end, which is outside of the body, that is where a syringe full of thrombolytic substance can be injected, and that will go in that area where the clot is formed, and it will break down the clot and clear that blood vessels. And the person will get relief from the stroke, which is important. Otherwise, the part of that brain would not function, and that will be a permanent damage of the brain. Here, how this blood platelet sits there and forms a clot in the blood vessel. This process is called thrombosis. When the blood vessels inside this is a vein, and you can tell this is a vein because the vein has valve, one-way valve, that allows the blood to flow towards the heart. And this area where blood clot is sitting and forming, blocking the passage, this process is called thrombosis. The formation of blood clot within a blood vessels when there is no cut there. It just happens inside spontaneously, just because this person is prone to form clot because of many different disease conditions. One of them is diabetic, and their platelet, they are always forming blood clot inside. Thrombosis is a formation of blood clot. Now, coagulants is a substance, a drug that also promote and allow the blood to coagulate. Coagulant is an external substance. It's a drug that a surgeon can give to a patient to help them form blood coagulation. When do they need it? when there is a external method used to cause bleeding, like surgery. When the surgeon is incising, they are causing bleeding, and that is when they need coagulant in form of hemostatic agent. Coagulant has two major categories. Hemostatics, these are agents like drugs are used during the surgical procedure. And then systemic coagulant, generally used during the surgery, like they will give this through the IV. Hemostatics are topical. You use it right on where there is bleeding. Like you see a muscle belly is bleeding, you apply hemostatic agent there. But if you wanna have blood coagulant transmit throughout the body by the blood vessels, then we have intravenous systemic coagulant. That is when surgeon tells the anesthesia, please give them protamine sulfate, which is one of the systemic coagulant. This systemic anticoagulant, systemic coagulants can be given through intravenous route. So systemic and hemostatic. Topical, one of them is topical, another one is through the IV. You as a surgical tech will deal with hemostatics, which are topical agents. Mostly you'll use this as a topical agent. Anesthesiologist or nurse, they will use this systemic coagulants by putting it through the IV. Now, topical hemostatics. That is our part for our process during the surgery we provide. Here are some examples. This is a oxidized cellulose component. We have it on our back table. Circulator opens it for us. It is a sterile, this sponge-like substance, wispy, kind of like a wispy sponge-like substance. We give it to the surgeon, and surgeon breaks it down and applies where it is bleeding. Or we have this cellulose sponge called gel foam, cellulose foam called gel foam. We can give it to the surgeon and they can apply it where there is a break in the blood vessels. So those are topical hemostatics. They will control any type of bleeding, not just only capillary bleeding, but also major bleeding also can be controlled. Depending on how much, if it is an artery that is open and bleeding, that is when we consider it major arterial or venous bleeding. That is when we need clamp. That is when we need mechanical way of hemostasis. We need a vascular clamp to clamp it. The regular topical hemostatics is not going to stop the bleeding because it is going to flush with the blood, because the force of the blood vessel will flush everything out. So for that major bleeder, we need clamps, special vascular clamps. But if we have minor bleeding, then we can use this topical hemostatic agent. Films, It's like a little gel film, powder, sponge, and solutions. These are many different ways that we find these topical hemostatics. Like here, you can see topical hemostatics is applied. And mechanical action is by way of using clamps. We have vascular clamps, we have hemostats, right, mixtures, Kelly clamps. Those can be used to control bleeding. Now, ligature is a suture material, free tie, like silk. Silk tie, 18 inches long or 30 inches long. Or we have tie with a needle attached to it. We call it stick tie. So when we are using these suture material, free tie, tie on a passer means a suture is passed using a hemostat or clamp. A stick tie means when the suture is actually got a needle attached to it, so they can use needle holder to use it. So ligature is the process by which we use suture material to ligate those vessels, tie those vessels. We have clips. We have hemoclips. Hemo means blood, and blood vessels related clips. These clips are disposable, and nowadays we use disposable clips. We don't use non-disposable clips anymore, but we have clip applier. We use clip applier to place these small, medium, large clips depending on the bleeding blood vessels, and we apply it on the blood vessels. When it is a small bleeder, oozing, then we can apply sponge as a tamponade. We put pressure with a Ratex or lap sponges for a while to stop the bleeding process by pressure. When we are using closing blood vessels, when we are suturing blood vessels, and when we place the suture with the needle cuts through the blood vessels, needle punctures through the blood vessels, penetrates through the blood vessels to go through. When it penetrates through the blood vessels, those tiny microscopic needle holes during the suturing process requires some type of buttress. And that buttress type of mechanism can be provided by these pledgets. Pledgets are nothing but a section of tiny sponge cut previously. It could be Teflon or it could be a cellulose sponge. Mostly we use Teflon-made synthetic pledgets. So we place pledgets along these needle holes, and they're sutured on top of that needle hole to put outside pressure, and the small needle hole eventually stops bleeding, and it will work as a pledgets there. So mechanical methods, clamps, starting from hemostats to large clamp-like aortic coagulation clamp, aortic clamp, or Satinsky clamp, or DeBakey clamps, or any type of vascular clamps. can be used to control bleeding. To control bleeding of the aorta, we got the largest clamp, which is called coarctation aortic clamp, that is normally used when they are operating on the aorta. And ligature, suture material, clips, it's like stainless steel clip or titanium clips, sponges like latex or lap sponges, and pledges like Teflon, pre-cut, small sections, like maybe those sections are probably 1/4 of a postage size. So tiny little pledges can be applied. Other types of mechanical methods for hemostasis is bone wax. Bone wax comes from beeswax, sterilized beeswax, and they are really very effective in controlling bone bleeding. When surgeon incises or excises bone using ronger or kerosene or even saw blade, the bone starts to bleed. The edge of the bone starts to bleed. And bone wax can be applied as a mechanical sealer to stop the bone wax, stop the bone bleeding. Usually for orthopedic surgery or neurosurgery, we use bone wax routinely. By using suction, we can aspirate the blood and the body fluid so that the surgical site is exposed again. So we have a clear surgical site. So suctioning is another mechanical way to expose the cavity and suction out the blood or body fluid from that cavity. When we see or we find there may be a active bleeding process even after the surgery, small, very tiny active bleeding process going on even after the surgery. And when they encountered that, the surgeon asked for drains. And we have many different types of drains depending on the wound. So when they're closing the wound, they will place the drain and close that wound tightly. And the drain will then suction out or drain the fluid and the blood from inside that that area where there is blood bleeding is active. Usually this happens if there is a dead space, like a space in between the closure, and that area tends to bleed, and this is where they need to put a drain in there. For example, a patient has cancer of the breast and they have radical mastectomy, which is the breast tissue resection, removal. After the removal, there is a pocket, a dead space created, and that even after controlling during the surgery with the hemostatic agent and mechanical or chemical, it tends to bleed very slowly, but over the time, that bleeding needs to be evacuated from that area. Otherwise, there will be a large hematoma formation. Hematoma will not will prevent wound closure. So in order to prevent that hematoma, surgeon will place a couple of drains in there and suture the drain, anchor the drain, and leave the drain there and the drain, one end will be inside that pocket created by the mastectomy, other end will be hooked up to a drain's reservoir. And time to time, the nurse who is taking care of the patient after the surgery will empty that reservoir, and surgeon will check the drain uh, response a couple of times a day. And then when there is no more blood coming out, no more fluid coming out through the drain, they will take the anchor off, and slowly they will pull the drain out of that wound, and the wound will heal appropriately. So drain is another methods by which a hematoma or hemorrhage can be controlled. Tourniquet is a equipment routinely used for extremity, upper or lower. If they're working on hand, they may use a tourniquet on the arm, and before the tourniquet used, they will exsanguinate. They will squeeze the blood out of that arm, out of that hand, out of that arm, so that they have a bloodless field to work. So, for example, if they're doing carpal tunnel surgery, and the surgeon may decide, okay, we're going to use tourniquet, and we will exsanguinate or squeeze the blood out of that hand to free up a bloodless field to work during the carpal tunnel surgery. And after the surgery is done, then they will deflate that tourniquet, and the blood will come back to that site, and then they will control the bleeding accordingly. So tourniquet is like a blood pressure cuff. It's same principle like the blood pressure cuff works, but it's larger. Blood pressure cuffs are good for arm, but the tourniquets, you can apply it on the thigh also. So it's larger, and it has a lot more force to hold the blood away from that field. So tourniquet is a way, when it is inflated, this will give hemostasis to that field, because there will be no blood coming. And when tourniquet is deflated, the blood will come back to that area like before. But by then, surgeon will have the surgery done. So everything is open, and the repair is done, and everything is closed properly with suture. So there will be no bleeding. That is another way orthopedic surgeon, they like to control bleeding of extremity. Like they're working on a knee, they're working on elbow, but they cannot do it on shoulder or hip. As you can see, where are they going to apply the tourniquet? There's no place to apply tourniquet when they're working on the hip, right? So tourniquet. Another way, very, very routinely, surgeons use this. It's called cautery. Using electrosurgical unit, or mainly we call it BOVI. This machine uses high frequency electric energy to coagulate bleeding vessels. And also it can cut tissue during the surgery. They have a way they can use it to control bleeding. That is another mechanical method for hemostasis. And this cautery is always available, and surgeons use them frequently. When they see anything starts to bleed, They will use the cautery and coagulate that bleeding vessels and stops the bleeding to start. So bleeding vessels can be stopped by using electrocautery. It's very, very essential for our today's surgery. Mechanical way of hemostasis. Now, hemostatic agent, we've been talking about this, that we have hemostatic agent. Absorbable gelatin is manufactured by the manufacturing companies in the plant. Comes from animal. And this is compressed and structured as if like a little foam sponge, like you see here, like a little strip of foam sponge, and it's dry. When it is first manufactured, then it is shaped like this or larger, and they're packaged sterilely using manufacturer's gamma ray radiation. So it is sterile inside the package, and we open it during our surgery. Two forms are available. One is like this type of foam. Another one is like a film. So film is very thin, as you can imagine, and foam is little, like a little width to it. These alone can be used, or it can be moistened with saline or thrombin. Thrombin is a drug, topical anesthetic agent, sorry, topical hemostatic agent, thrombin. Saline or thrombin can be sprayed on this gel foam, and that gel foam then can be applied to the bleeding site, and it will control the bleeding. It will provide hemostasis. Gel film and gel foam. Then we have this substance called avitin. Avitin can be used like a powder shape, or it can have a strip-like shape. So avitin is expensive, so we use it very, very cautiously, so we don't waste any. It is a very good anesthetic agent, and it can be applied to the surface where the bleeding is occurring, and it is going to stop the bleeding right away. Avitin powder or strip. Now, avitin, we don't use it for injection. It is used on the surface. We have other substance that we can use it for injection. We'll go over it. So we get the avitin from a bottle. So circulator usually have them on their back table ahead of time. And when we are encountering bleeding, surgeon may ask for avitin. Then what we do, we get a container, and the circulator will open the avitin powder, and we will get a bottle, and we will get the inner bottle, which is also sterile, and open that inner bottle, sterile inner bottle on our back table, and get that powder substance. Now, if we need this strip, then it is also in a package, The inner package we will get from the circulator, which is sterile, and we will carefully open that inner package, and it will be like a shape of a twice the shape of a postage stamp. And then we will not use our glove hand. We're going to use forceps, tissue forceps. And using the tissue forceps, we can pass that strip to the surgeon, and the surgeon will apply it to the bleeding area. And we have to be careful because this is expensive, so we don't waste any of this Habitant powder. So after a few minutes, when Habitant stops the bleeding, surgeon may decide to keep it there or may decide to just pick up the excess from there and clear that area from that excess powder. Oxidized cellulose. Oxidized cellulose are another type of hemostatic agent. These are available like a little sponge material. And this material we get from the circulator, and we use a tissue forceps, and just like the Habitant, we give it to the surgeon and they can use it on the bleeder. Oxidized cellulose, neurosurgeon and otorhinolaryngology or ENT surgeon, they like to use it because of the shape. Neurosurgeon sometimes works through a tiny cavity, and the ENT surgeon, they also likes to work through tiny, cavity quite often, the nasal passage or ear passage. So this oxidized cellulose perfectly fits their need. It's not large, and it can be applied by using a narrow tissue forceps, oxidized cellulose. Here are some oxidized cellulose example. Surgicel, this is like a surgical silk, oxidized cellulose, but it is available as a strip of silk material. This can be cut in many different sizes during the surgery. We usually know from the preference that which surgeon likes to use Surgicel or which surgeon likes to use Oxycel. Oxycel is like a cotton, like this here, white cotton kind of gauze, kind of strip of gauze, and Surgicel is like a little silk kind of formation. GYN surgeon, they prefer Surgicel a lot. They like to use it on the pedicle of the uterus. When they cut through the pedicle, they bleed, and they like to apply Surgicel and hold on to that Surgicel for a few minutes, and this will stop the bleeding. Vascular surgeon, they like both Oxycel and Surgicel. They open vessels, and when they bleed, they will apply Surgicel onto it and then apply pressure with the lap sponges. After a couple of minutes, that will stop the bleeding. So Surgicel and Oxycel is rather cheaper alternative than Habitant. Habitant is expensive. Surgicel and Oxycel is not expensive at all. So surgeon likes to use this first before they move to the avidin. Thrombin is a substance, drugs made from bovine cattle blood. So it's an animal derived product, came from cattle bovine blood. There is a way they extract this chemical from the blood, and that is packaged as thrombin. It is measured as a unit rather than milligram. They will say 1,000 unit of 1 million, 100,000 millions, 100,000 units of thrombin per 1,000 cc of saline. They will mix it up. Thrombin can be applied directly. You can draw it up in a syringe and give it to the surgeon. They can apply the concentrated thrombin, or you can use thrombin, mix it with saline and dilute it, and use that irrigation as a thrombin irrigation. You can take the thrombin out of the bottle using syringe and spray it on the gel foam, and then apply the gel foam to the bleeder. So surgeon may ask you, pre-cut gel foam, tiny pieces, like 1/4 inches, very tiny little sections. Put them in a petri dish. Petri dish, a sterile one, you can have opened by the circulator. You can put those gel foam pre-cut on a petri dish and then spray the thrombin on them. So these gel foams will be soaked in thrombin, and the surgeon will use bayonet forceps and pick up each little piece and apply it to the bleeder and keep it there for a while so the thrombin and the gel foam starts to act. And we told you bone wax comes from beeswax, and you can open the package, put it on a little instruments tip. Usually we put it on freer and give it to the surgeon as if you are handing a pencil to the surgeon. And beeswax, or that bone wax, is widely used for orthopedic cases and neuro cases. When they're doing spine case, their laminectomy, or they're doing this resection of knee, they will use a lot of these bone waxes. We used to use these chemical hemostatic agent phenol way back during the World War. Back then, we didn't have enough good hemostatic agent. They used to use phenol, that carbolic acid, and alcohol mix to neutralize the bleeding. Some older folks, surgeons, they still have this old school technique of using a little bit of phenol and carbolic acid and alcohol when they are doing appendectomy procedure. But we don't see them at all, very frequently at all in the surgery anymore. Chemical hemostatic agents are called styptics, anti-hemorrhagics. They will contract the tissue and seal the injured blood vessels. Systemic coagulants which goes through the blood itself. so they have to go through the blood vessels. So they are administered through the IV, mostly through the IV, or intramuscular, by mouth. Someone can take as a tablet form, or can be introduced into the sub-Q. You find many different such systemic coagulation method. Calcium salt. This is a mineral that can be given during the surgery through IV. You could have vitamin K. This vitamin is required for blood clot formation. The fibrinogen function is a step that requires vitamin K or potassium. So when the patient is lacking potassium, anesthesia can give potassium through the IV. Anticoagulants, these are basically drugs given to interfere, to prevent with blood clot formation. But anticoagulants and the clot breaker, they have two different mechanisms. Anticoagulant can be used during the surgery to prevent clot formation, but it really doesn't work efficiently to dissolve any existing clot. For that, you need thrombolytics. Thrombolytics is a component that we talked about, is a drug that can break down clot, dissolve it totally. But anticoagulant, it can prevent future clot formation. For example, when a surgeon is thinking that his process of his procedure is going to have trauma to the blood vessels, and it is going to form clot, then the surgeon can request anesthesia that I'm going to clamp the major artery here, and can you give anticoagulants through IV so I don't encounter any type of excessive blood clot formation. So anesthesia can open a bottle and take the anticoagulant and inject it into the IV bag, and that will circulate through the body and work as an anticoagulant to prevent any blood clot formation. So the surgeon can work without any blood clot problem. Now, when they are given anticoagulant, they also need to reverse the effect. So if the anticoagulant is circulating in the blood, in the blood vessels, and blood clotting, normal blood clotting action is prevented, that is also not good. So they need to have the patient go back to the normal situation again, normal condition again, So after they're given anticoagulants such as heparin sulfate, which is very, very popular, commonly used anticoagulant given by the IV. And you can also use this heparin sulfate on your back, from your back table, using a large syringe, like 35 cc syringe, and a syringe filter needle, which you can use, give it to the surgeon. They can directly flush the open blood vessels with heparin sulfate. Normally, when they're working in the blood vessels, they will ask you to have heparin sulfate on your back table mixed with normal saline. So heparin sulfate circulator will open up the bottle and give you a few cc's of heparin sulfate in a pitcher full of saline, and you will use 35 cc syringe to draw up, or 60 cc syringe, depending on surgeon's preference. You draw it up, this heparin sulfate makes saline for anticoagulation irrigation. When they're opening the blood vessels and when they're closing the blood vessels again, before they close, they will use heparin sulfate, so the blood vessels are not going to bring in, start forming clot. If they do, then the blood vessel anastomosis surgery will not be successful. There will be blood clots sitting there and the blood vessels will be blocked. For example, a patient came in for a vascular surgery because this patient has a big blood clot inside their femoral artery. The patient's femoral artery has a big blood clot, and because of that big blood clot sitting there in the femoral artery, the blood is not flowing down to the toes, down to the ankle, and the ankle is dying because it's not getting the oxygen or the nutrients for a while. To prevent the necrosis of that ankle, the surgeon decides to do a bypass surgery. They said, okay, the area the blood vessels are damaged, we cannot use it anymore. We're going to use a graft to bypass the damaged femoral artery. So they put a graft proximal to that damaged area and attach it there. And when they attach it, they had to cut open that area a little bit, few millimeters, and they will use the suture to attach that graft there, and then tunnel the graft under the skin all the way down to the cup muscle. That area, they have another blood vessels, which is either popliteal or tibial artery. They will hook it up there also. When they're doing this, the body senses a foreign material because the graft is foreign. Although body has low resistance to this type of graft because these grafts are experimented and found safe, but still the body will produce some clotting mechanism because the blood vessels are open, it was bleeding, and naturally blood sense, oh, there is a bleeder, let's go sit there and form clot. That's the natural, natural phenomenon. Now that is going to damage the new graft. If you have blood clot sitting in the new graft, then the blood is not flowing down to the ankle. Same problem. The patient's not going to have a uh, uh, blood down to the ankle and toe, and the ankle is slowly going to die. To prevent that, surgeon will ask the anesthesia, give anticoagulant, because I'm going to open the blood vessels and the blood vessels are going to think there is a bleeding. Let's go sit there and clot, prevent that clot formation, natural clot formation. So I can work efficiently. I can make the graft work only if you give heparin sulfate to this patient, and that heparin sulfate is going to take care of prevent any type of blood coagulation, any type of blood clotting formation, and failing my graft. To prevent failure of the graft, now the heparin is given. Anesthesia gave it IV, so it's circulating in the blood. You gave heparin sulfate in a syringe. Now, surgeon is flushing that at the juncture of the anastomosis, where they're making the suture, where they're attaching the graft. So by doing this anticoagulation with the heparin sulfate during this femoral popliteal bypass graft surgery, this graft is going to live, and this graft is going to bring in oxygenated blood to the ankle, and the patient's ankle will live. So for this type of vascular surgery, they use anticoagulant like heparin sulfate almost always. 99.999 cases, all cases, you'll have heparin sulfate on your back table, and the anesthesia will give heparin sulfate through the IV. So that's anticoagulant, action of anticoagulant. Now, we have anticoagulant given through this Lovenox. That is, anesthesia gives that. That's another component, just like heparin. We have anticoagulant just like oral. A person can have anticoagulant before coming to the surgery, oral anticoagulant. They can take it with water. And such anticoagulant that we have available as oral are like this. Very common one. We call it, we know everybody has it at their home, aspirin. Acetyl salicylic acid, ASA, aspirin. Aspirin, once taken, it can prevent any clot formation. And stronger medicine is warfarin or Coumadin. This works very efficiently also. It is very strong medicine. Those two are taken by mouth. So we have seen anticoagulant by mouth, by IV, and by muscle, by sub-Q. And we have seen anticoagulant also given directly into the blood vessels by using syringe, the heparin sulfate. Remember the heparin sulfate. You're going to use it in surgery. Very routinely, we use heparin sulfate. Thrombolytics, on the other hand, rather stronger and effective medicine discovered or invented these days, they break down clots, blood clots. When persons having heart attack, there is a blood clot sitting in the coronary artery, which is called thrombosis. Thrombos means blood clot, and thrombosis is a blood clot formation blocking the artery of the heart or blocking a major branch of vessel in the brain. Person is dying, and that can be prevented by using thrombolytics. There are many thrombolytics available in the emergency room. They will use it directly, and that will dissolve the blood clots. And of course, when you are using that extraordinary measure of dissolving blood clot, side effect would be hemorrhage. The person is going to bleed. And that is what we want. We want the person to bleed, so all the blood clots are flushed out of the system. So the blood clot problem would be gone. There are thrombolytics like here, streptokinase, urokinase, anti-striplase, alteplase. All of these A's means enzyme. These are some synthetic enzyme that dissolves the blood clot. So no thrombolytics also. So systemic and mechanical and chemical hemostasis, which is required, in order to have a really a surgery can be done efficiently. Otherwise, surgeon will lose the exposure. And at the same time, we're seeing that we need both anticoagulants and coagulants for our surgery. Now we talked about heparin sulfate. When we use heparin sulfate as our drug for blood vessels related surgery, to have the blood vessels not going to form the clot during the bleed during the surgery and cause problem, clot formation. This action can be reversed. Reverse action is done by another drug called protamine sulfate. So when the heparin sulfate is used in large quantity by the anesthesia, this person's is going to hemorrhage. It's not going to form blood clot for a long period of time. So a tiny little bit of trauma, a tiny little bit of cut during this time, this person is going to bleed and bleed and bleed. Again, we don't want that either. After the surgery, we want everything to go back to normal, right? surgery is done, that femoral popliteal bypass graft is working, blood is going down to the ankle, surgery is done, success. Now, we want the person to go back to natural health again. So that is when surgeon also required, ask the anesthesia, now I'm done, I'm putting dressing on, can you please give a milligram of protamine sulfate? They'll say the actual dosage. Anesthesia will drop the protamine sulfate from their storage, and they will give protamine sulfate inside that IV. IV is going to circulate that protamine sulfate and antagonistically neutralize the heparin sulfate. Protamine sulfate neutralizes heparin sulfate. It is the antagonist. It reverses the effect of heparin sulfate by neutralizing heparin. So question comes, how do you prevent blood clot formation during the surgery? You'll get a list of items. One of the items could be heparin sulfate, and that is correct answer. And then you may have a question, after the surgery is done, when the patient wants to go back to normal status, what is given to reverse the effect of heparin sulfate? And the correct answer would be protamine sulfate, which is the reversal of heparin sulfate. In the terminology we use is antagonist for heparin. So heparin sulfate and protamine sulfate, you're going to have it in your operating room when you are dealing with blood vessel related surgery. All right. So this is where hemostasis related part of the chapter 8 ends. And I'm going to stop the recording process also.